thank you all for being here. And I can see it's almost a full house. I see a few familiar faces in the crowd and some that I might see in the near future. So welcome one and all. One complaint I always receive is you can't hear me in the back. So if you can't hear me in the back, let me know. I'll speak louder. Louder? Louder. Louder. All right, well, without, and another apology, if this guy offends you, this is my wife's choice, not mine. So I plead allegiance to no one. Okay? Well, I do, but not tonight. So we'll move ahead here. So this is a new and an exciting field in the field of medicine and cardiology in particular. And this is something we brought to the county and to this area recently in the last year and a half. And the program here has grown by leaps and bounds. There's a lot of people who have the problem, and the knowledge about atrial fibrillation and what it does and what problems it creates and how to manage it is somewhat lacking. So we thought that this would be a great opportunity for me to talk to people who either have the condition, know someone who has the condition, or just want to know about it and see if they're at risk, or do they have the symptoms, do they need to be screened for it. So this is what the normal electrical activity of your heart looks like. Okay, this is what's called, this is a perfectly normal strip of EKG. Anytime you go to a doctor, you're in the hospital, they hook you up to a monitor, this is what they see. They see what's called a P wave. I'll keep it very simple. This is the activation of the top chamber of the heart and the QRS complex, which is the bottom chamber of the heart. Because the top and bottom beat in sync. Again, no allegiance, but this is from 1949. So you see, nice and symmetric, well organized, right? So this is what atrial fibrillation looks like. Atrial fibrillation essentially means chaos and disorganization in the top chambers of the heart. There is no pattern, there is no organization, it's completely chaotic and random electrical activity on the top of the heart. So you can see, instead of having these well-formed and well-organized waves, you have all these irregular and erratic electrical activity going on at the top. The bottom still looks narrow, it just is irregular, but the top gets extremely irregular and erratic. So the heart goes out of sync. Instead of being in sync, goes out of sync. That's atrial fibrillation coming from the top of the heart. This is a traffic jam somewhere in India. I don't know. This is chaos. Okay, so organization and chaos. Just to give you an illustration. I tried to make the slides more visual, less words. There are some places I can't get away without words, but I try to make it as visual as possible, just to understand. So why is atrial fibrillation a problem? Why is it a problem? This is what normal is. Again, a different diagram here, just to show you the same thing. You see this normal, organized electrical activity in the heart, starts from the top, goes down to the bottom, all symmetric. This is atrial fibrillation, complete disorganization, and the bottom follows it, but in a very erratic manner, with a loss of synchrony between the top and the bottom, leading to problems between the top and the bottom chamber. So why is this a problem again? So how does it matter if your heart is in sync or is out of sync? Why? And why do you get it? Why is the problem? Why me? Right? Everybody asks, why did I get it? Well, none of us are getting younger. A lot of you have told me I'm young. I don't feel it, but nobody's getting younger. Conditions like diabetes, thyroid disorders, high thyroid levels, thyroid overactivity can cause that. High blood pressure. As you get older, your arteries get stiffer because your heart's been pumping and they've been flowing blood for the last 40, 50, 60 years. They get stiff, and just like that, the heart gets stiff. Things like congestive heart failure, that can increase the pressure in the heart. A prior heart attack, prior stents, prior bypass surgery, any of those. One thing we figured out in this field is sleep apnea is a big contributor of atrial fibrillation. So anybody, if you see me and if I feel that there is even a remote chance that you have sleep apnea, a lot of you have been through a sleep study, and I will make you go through a sleep study, because to prevent progression of the condition as well as other incidental heart problems like high blood pressure and congestive heart failure, it is extremely important to get sleep apnea diagnosed and treated. Alcohol and caffeine don't help, they're obviously triggers. And lastly, genetics. We don't quite understand why it passes down generations. Why do we have it? Why do we have genetic involvement? There is no particular genetic test which can be done, but my dad has atrial fibrillation. What do I do about it? I don't know, I'm scared, that's it. All right, what symptoms could you have from this condition? What do you feel? Well, a lot of people will have no symptoms from atrial fibrillation. The reason for that is, unfortunately, as we get older, our functional capacity, the ability of our body to perform physical activity goes down. So there are a lot of people who are older who don't have a high functional capacity, where even if you lose let's say you have bad arthritis, you can't walk more than 50 yards. You're not going to notice the loss of physical capacity and cardiac function when you go into atrial fibrillation, simply because the limiting factor is not your heart's output, it is your arthritis. So obviously a lot of people may not experience any symptoms, but the common things you can watch out for are things like heart fluttering, heart pounding, some feel flip-flopping in their heart. Some people have told me, I feel a fish in my heart. Chest pain, pressure, discomfort. When your heart rate goes really fast, you can feel, obviously have heart pain, shortness of breath, you get winded easily when you walk. When you were able to walk 100 yards before, now you can walk 25 yards before you start getting tired, short of breath. Dizziness, especially if you have your heart rate going very fast or very slow with this, you can feel dizzy. Obviously stroke or mini strokes, we'll focus more on that in a little bit. And rarely urinary frequency. I had a gentleman who told me that the severity of his atrial fibrillation attack, he can tell by how much he pees. The reason is, every time your heart goes in and out of atrial fibrillation, there is a hormone released called natriuretic peptide from the top chamber, just not to go into a lot of details, and that makes you pee a lot. So the way he would tell me how bad his attack was how much he would pee. So I thought that was interesting. It's only one I've heard. So I like this diagram. I found this recently. Heart palpitations, what do they mean? They could mean you're dying, or they could mean you're in love, right? But I don't know which one this is. So anyways, how do we find out that we have atrial fibrillation? How do we screen you if you have a problem? If you say, you know what, I feel something's wrong, what's the next step? And EKG is the simplest way to diagnose. EKG is what everybody must have had an EKG where you go to the doctor's office, they put a few stickies on you, and they run a strip. You look at it, and the machine reads it, and they confirm that, okay, you have atrial fibrillation, it's normal. That is about a 10-second perspective, or an 8-second perspective. That does not tell you what happens when you go home, when you're sleeping at night. So the more common things are in these heart monitors. You can wear it for a day, you can wear it for a couple of days. Those are the ones which we put in the office, and you have to take it on. You wear them all the time when you have it on. There are longer term monitors. Some people have episodes once every 2 weeks. Others have an episode every 3 months. So depending on what stage of the disease you're in, you could have a monitor for 3 or 4 weeks if you have an episode every week. On the other hand, if you have an episode every 6 months, you probably need an implantable monitor, which has a battery life of 2 or 3 years. It stays in your body, picks up an episode, tells us what's going on, and allows us to treat you and manage you accordingly. These are interesting things people have come up with. The Fitbit monitors. I don't know how many people have used a Fitbit or no. So I see a few hands there. So a Fitbit is a monitor. It goes on your wrist. It records your heart's electrical activity. It is able to tell you whether you're in normal rhythm, out of normal rhythm. There is this other monitoring device which can actually give you an EKG. You need a smartphone. It talks with your phone using Bluetooth, and you can get an EKG off it, and they can actually give you a diagnosis, or you can bring it to your doctor's office and they can take a look at it and say, listen, this was normal or this was not normal. Again, as you said, the duration of monitoring depends on how long have you had symptoms, how frequently do you have symptoms, and how deep do we want to search for symptoms and for a condition. Why is it a problem? Why is atrial fibrillation a problem? Why do we care if we have atrial fibrillation? Well, the biggest thing is the increased chance of stroke. So there is a scoring system they figured out. You get a score of about up to 9 points. And on average, each point gets you a 1.5% higher risk of stroke per year. Okay, so if you have 0 out of 9, that's great. Your stroke risk is what it is for the normal population. I mean, people have strokes who don't have atrial fibrillation. And then as you get higher and higher, your stroke risk gets higher. One of the rare conditions where being a female confers you a higher risk of stroke than men. Okay, one of the rare heart conditions that happens. Getting older, if you're above 65, especially if you're above 75. If you're diabetic, your chance of having a stroke goes up if you have atrial fibrillation. High blood pressure, obviously if you've had a prior stroke, and then things like congestive heart failure, having a low heart function, having heart disease where you've had blockages in your heart arteries, stents in your heart, or bypass surgery, things like that. And the other thing is, over time, atrial fibrillation tends to become chronic. Sorry. Once it becomes chronic, your exercise capacity, especially if you're very functional, goes down over time. You start developing signs and symptoms of congestive heart failure where you can't exercise and perform as much physical activity as you would be able to do otherwise, and the condition eventually becomes chronic. So this is trying to look at, this is a graph, it's a little complicated, but focus with me on this for a few minutes. So on the bottom, it's from a medical journal, but what I want to show you is, look at the bottom. This is time as you go on. This is the total risk of having any kind of heart disease. So they took a bunch of people who had a normal rhythm and people who had purely atrial fibrillation, nothing else, just atrial fibrillation. And they followed them over the next 4 to 6 years. What happened is the likelihood of developing heart disease of any kind, not just stroke or not just atrial fibrillation, in the normal population, I don't have the details on how old they were, but they were, what we do in medicine is controlling. We match them where they're about the same age, the same groups, they have the same risk factors, same amount of hypertension and things like that. Whereas people who develop atrial fibrillation had a 50% chance of developing other heart disease in the next 5 to 6 years, which is a lot. It tells you that this is a marker of badness or ill heart health coming in the future, and we've got to do something about it and be proactive about it. So this is another heart diagram, and this illustrates why it is a problem. So look carefully with me. This is a heart. This is what's called the aortic valve for some people who may have had valve surgery or know someone who's had valve surgery. And this is a bad thing in the heart. It's called an appendage. It's called the left atrial appendage. It's like the appendix in your belly. It doesn't serve any purpose. It was functional and active in lower mammals. In humans, it doesn't serve any purpose and just creates problems. So here is someone who has a clot in their heart, in their appendage. Okay? No clot in the appendage. No clot in the brain. Clot in the brain. Okay? So this is what a stroke looks like. The reason this is important is atrial fibrillation is responsible for a very, very large percentage of strokes in the population. Again, stroke, clot in the heart, no clot in the heart, no clot in the brain, clot goes to the brain. Okay? Clot in the brain, big problem, hard to fix. Right? Some of you may have experienced strokes, some of you may know people who have experienced strokes, very difficult to deal with. Many strokes, you get lucky, you scrape through. A big stroke can often be very debilitating over time. So interestingly, if you analyze MRI scans, the brain scans of people who've had atrial fibrillation, even if they haven't had a major stroke, you see these things, they call these white matter changes. Your brain still has micro, small strokes, which actually over time will lead to earlier onset of dementia and memory problems and loss of cognitive function as you get older. So if you have atrial fibrillation, this risk, not just of having a big stroke, but many micro strokes also does go up. All right, this is one of the most common things I get asked. You want me to take rat poison? Yeah. So what do we do about a stroke risk, right? For the longest time we've used medications called warfarin or Coumadin, or depending on if you lived in Europe, escumerol or whatever it may be called, is a blood thinner. It's been around for about 50, 60 years. It is used to kill rats. It still is sold as rat poison, but what we do, obviously we give it to you in a very monitored dose where the levels are adjusted. The reason we do that is to prevent clots from forming in the appendage. Because once a clot forms in the appendage, it's just a matter of time where it breaks off, goes to the brain, causes a stroke. Who's seen this guy on television? All right, so there are newer agents which are blood thinners, things like Xarelto, things like Pradaxa. There are some other agents they haven't caught on yet. They want to focus on these important drugs because they can make money first off this, then go to the next one. And I don't know what else to say. Personally, some are better than others, but from a practical standpoint, there's not a lot of difference between all the blood thinners. I let you choose based on, if you're going to be on a blood thinner, what you feel comfortable with, what your insurance company approves, obviously that's a big driver, and what television channel if you watch Goldwater Law Firm, then you may not want one versus the other. I personally am opposed to marketing drugs to patients and from people coming after drug companies and suing them. I feel a decision to start a medicine should be an informed decision between a patient and their doctor. It should not be influenced by direct-to-consumer advertising about medical devices, about pacemakers, about heart things, about joint surgeries or anything like that. This should be done between the doctor and the patient and not, this is just my personal perspective, this guy shouldn't be there. So how many people have atrial fibrillation in the United States? It's interesting. A conservative estimate right now is about 1% of the population. The number is growing as we recognize more and more people who have atrial fibrillation. Unfortunately, sometimes the first sign of atrial fibrillation is a stroke. And often people who have strokes still do not get diagnosed with atrial fibrillation because they go in and out of atrial fibrillation. So they have a stroke, the atrial fibrillation goes away, yet when they show up in the hospital and they're in there for 2-3 days, it's your normal rhythm, nobody figures out what's the problem, and this happens again and again until finally you figure it out. And the number is expected to, as the population ages, as the obesity epidemic kicks in, as diabetes increases, high blood pressure increases, the likelihood of the atrial fibrillation going up in the population will be more and more. Keep getting the wrong one. So, a little medical knowledge. Try to focus, just to get an, there's a lot of terminology here, but just try to focus a diagram. So this is an average time that the condition takes to progress. How long? I hate to use the analogy of cancer. This is not cancer, but it explains it so nicely. So you have the first episode of atrial fibrillation. Some people tell me I've had heart skip beats for the last 25 years, and this just started. But typically, once you have a first episode, and the way they define atrial fibrillation is an episode lasting more than 6 minutes or so. So you have one episode, on average about 1.5 years, you will have a second where it becomes a recurrent problem. 3 years later, it has episodes where they last for weeks at a time. Okay, it lasts longer and longer. And finally, about 4 years later, from the first time, it becomes permanent. This is not everybody. Some people progress over 10 or 12 years. Other people progress over 6 months or 3 months. But these are the average time it takes to progress. Why is this important? If you had cancer, I don't want anybody to get cancer, but if you had cancer, would you rather be over here or would you rather be over here? Would you rather find out when you have stage 4 cancer? Would you rather find a small lump, have it taken out and be done? And this is the reason why this is important, because we have to understand that as the condition moves on, the likelihood of progression is higher and higher. We can't always stop the progression. A lot of people will go down this progression, and often they're found in this stage where they are in permanent atrial fibrillation, and that's perfectly fine. If you don't have any symptoms, you're out on a blood thinner, there is no need to do anything. If you have episodes where you stay in AFib all the time, a lot of people live in atrial fibrillation. It's perfectly fine. Your stroke risk is a little higher, even if you're on a blood thinner, than someone who had an episode, doesn't have any more episodes for whatever reason, but that's perfectly acceptable. It's a perfectly acceptable strategy to adopt. Anybody who has any questions with the slides, please feel free to raise your hand and we can take some questions. Anybody so far? We'll move on. So this is a new technology. I wanted to talk to you a little bit, educate people about the procedure. Some may have had it, some may be thinking about it, some may know people who need it or have had it. It is indicated for relief of symptoms from atrial fibrillation and for progression of the condition. It is done from the groin. There is no cuts, incisions, like an angiogram or a stent, except it's done, performed a little differently through the veins. It takes a little longer. It's done under general anesthesia, which means you're completely asleep. Unlike the angiogram, where you go to the hospital, they put you to sleep for a little bit, they give you some medicine. This is done where you're completely out. We can't have you move for it, and it is painful. And about 2 to 4 hours, depending on how much and how complex your condition is. Most people stay in the hospital overnight and go home the next day. Move on here. So why focus on treatment? Why try to jump on treatment? The condition, as I said, is easiest to fix, and I'll use common layperson terminology, when the episodes come and go and come and go. So when you're in this stage, where you have recurrent episodes but they stop on their own, yes?
Okay, I have a question. When you say episodes, are you talking about you actually feel your heart beating, or are you talking about there's chaos going on in your heart, it's going on, but you don't feel anything? Is that an episode, or what's exactly an episode?
So the definition of an episode is where you have atrial fibrillation in your heart, irrespective of your symptoms, going on for at least 30 seconds to 6 minutes. Okay, depends on where you reach, 30 seconds to 6 minutes. You have an episode. Whether you feel it or not, that time is sufficient to derange the clot, the blood in your heart to start clot formation and for scarring to start in the heart. So it does not matter whether you feel it or not. A lot of people have episodes where their heart rate is 180. When we have them wear a monitor, they don't feel it. Their heart rate is 180 at night, they go to sleep, they don't feel anything. But this is what is defined as an episode, so if that answers your question. So episodes come and go. Once episodes start lasting longer and longer as the disease condition progresses, much harder to treat, because the cat is out of the bag and now you got to go find it. Some people may require, this is just general knowledge about the procedure, what to expect when you see me or any other specialist who deals in this condition. Some people may require a trial of medications to keep them in normal rhythm, and something called cardioversion, where you put someone to sleep for a few minutes, put them on blood thinners before that, shock you, get you out of it. The reason that is done is to determine, do you really feel better when you're in normal rhythm? So let's say you go to see your cardiologist and he puts you on a blood thinner because he feels that your risk of stroke is high, and this atrial fibrillation doesn't go away. Well, then we got to figure out, is this the problem? Is this why you're short of breath? Or are you short of breath because you have sleep apnea, you have congestive heart failure or heart disease? So they may do what's called a cardioversion, where they put you in the hospital, put you to sleep, shock you, a quick shock, get you out of it, and assess your symptoms, see if you stay out of atrial fibrillation and you feel any better being out of atrial fibrillation. As this is, again, as I said, more for people who've been in it for weeks or months. If you've had atrial fibrillation for years, chances are nothing is going to keep you in normal rhythm. So the likelihood of it, in cardioversion, ablation working is lower. So unless we feel strongly that your symptoms are related to atrial fibrillation, we would not perform cardioversion or any advanced procedure on you. Candidacy for any kind of procedure, invasive or medical, has to be individualized. But if you have advanced heart disease, advanced lung disease, if you're on home oxygen, if you have a heart function ejection fraction of 20%, or if you've had atrial fibrillation, as I said, for 5-10 years, it is unlikely to work and it is unlikely to succeed, and the risks in those situations generally outweigh the benefits, and hence we don't recommend. Go ahead, Mary.
About the ablation, I've heard that if you have that done, it may not last.
Exactly. So excellent question. So that treatment has to be individualized to the patient. So if someone has a condition where I have had people who, so just to share someone's story, I have had someone who was 27, okay, had atrial fibrillation, had been in the hospital 4 times, got it fixed, got it done, moved on, because that was his only problem. I've had people who are 70, 75, but extremely healthy. This is their only medical problem. They get it fixed, they move on. It doesn't change anything. There are some who have congestive heart failure, who have sleep apnea, who weigh a little more than they should, whose hearts have a lot of scarring. When your heart does have a lot of scarring, when you have congestive heart failure, often you can't fix the problem completely. So in younger people or in people who are extremely healthy and who are otherwise athletes or not even athletes but who are regularly exercising, they can go up 2 flights of stairs without having to stop, good health, likely to work. Sometimes even younger people can have a lot of disease by the time we go in, and often in those people, even though we try, may not. Success rates is just moving on to your question. Success rate depends on where you are in the stage. Some people may need a second procedure. There is a different procedure which is offered, which is surgical. It's performed by a cardiac surgeon, not by myself, where they go from outside the heart. And sometimes they may actually do it on pump, where they do open heart surgery to fix the problem. There is someone who is so advanced that they can't fix the problem without open heart surgery. We would not even consider them for catheter ablation. We would recommend that they have surgical ablation or some, in rare cases, open heart procedures for atrial fibrillation. Other people may actually have this open heart procedure performed when they're having some kind of valve surgery. There are some here who may have had it and not know about it. So you were diagnosed as atrial fibrillation before surgery. The cardiac surgeon went in, and when he replaced your heart valve, he also did ablation for this, and it's worked. And you may not even know that you had the surgery during the time of your valve surgery. But others may need a second procedure. Generally, in my belief, if it doesn't work by the second time, it's not going to work. Sometimes there are people who had 4, 5, 6. I do not feel that is the right thing. There are only so many times that you can fix a broken bone or you can replace a knee. At some point of time, it's not going to work. You need to move on. Some others may require rhythm control medications, which is medicines to keep you in normal rhythm. And that's not our preference. The reason is a lot of the rhythm control medications may have a lot of side effects. Amiodarone is something which may be commonly prescribed. It's not something we like to keep you on for years on end because it can affect a lot of your organ systems. It requires a lot of monitoring. Some of the other medications also require monitoring. And so the whole point of doing a procedure is to try to get you off medication. Now you may need to be on medicines, but we try to avoid having you on these rhythm control medications for this reason. As with everything else in your body, the lifestyle changes, regular exercise, staying active, staying fit. If you have sleep apnea, you've got to wear your CPAP machine. That is so critical because I'll diverge a little bit to talk about sleep apnea. I'm very passionate about it. Why is that? Every time you have an episode of sleep apnea, you may have about 40 or 50 or 60 of those every night if you have sleep apnea, if you have bad sleep apnea. You stop breathing. When you stop breathing, and you suddenly, your partner, your spouse, your wife, or husband, or someone who sleeps with you may tell you, stop breathing. And then if they're very concerned, they may shake you and wake you up, are you still alive? But those episodes, when they happen,
I do my wife like it all the time. Wake up, wake up.
You're not getting dinner tonight, I can tell you that. So when this happens, your heart suffers a lot of stress and your lungs suffer a lot of stress. The reason that happens is your airway blocks off. Sleep apnea happens because your tongue falls back, your airway gets blocked off. How do you open that airway? You suddenly have to push really hard. You're not going to wake up for it, you have to push hard. But that push, the pressure goes up. The pressure in your heart rises about 10-15 millimeters of mercury. That's a lot for the heart. And imagine this happening 50, 40, 50, 60 times every night. What the sleep apnea machine does, or any kind of procedure you have to fix it, is you have to wear this uncomfortable mask, I agree, but it applies pressure and prevents your airway from closing off those 50 times every night and prevents the strain on your heart. And it's been time and again shown that treating your sleep apnea will reduce your risk of atrial fibrillation, stroke, high blood pressure, heart failure, coronary artery disease, anything that you can imagine. Low salt diet. Again, anybody who's been in the office to see me, I'm very passionate about it, eat less salt. Why is that? They're trying to kill us with all these artificial foods, adding salt in everything. It's amazing. Milk has salt. Who knew milk would have salt? But milk has salt in it. And so anything processed, anything which you buy in a drive-thru has enough salt for you, which would last you a day. That's often, or 2 days, and that's just one meal, or half a meal sometimes. So low salt diet, very helpful. Regular aerobic exercise, walking on a treadmill, walking outside, swimming, water aerobics, whatever you can do helps. Coming off blood thinners. This is another thing people ask me. When can I come off blood thinners? Being younger helps. Not having any other existing medical conditions helps. If you're diabetic, if you have underlying heart disease, if you have congestive heart failure, if you're above 75, if you're a female, I apologize, or if you have a prior stroke or heart attack, these are things which put you at they put you in a different spectrum. And if you have more than one, definitely. Now, if we go inside and we find that, listen, you are 75 and you have high blood pressure, but you have no scarring, or appendage, that remember we go back to the appendages. I have a love-hate relationship with this appendage. So if your appendage is extremely healthy and it squeezes really well, and we monitor you after 3 or 6 months, and you have a very nice squeeze and you have no more episodes of atrial fibrillation, that is someone who can come off blood thinners, because there the problem was only electrical. We fixed the problem. Your heart is otherwise healthy. You stop your blood thinner, go on aspirin or not even aspirin, and move on. On the other hand, if we find that you have any of the other risk factors, things like, as we just spoke about, diabetes, congestive heart failure, if you're some 90-year-olds, I would feel very uncomfortable taking you off a blood thinner. So, age, big factor. The 27 or 28-year-old is not on any blood thinners, but he's 27. I'm not 27. So we'll walk through a case here. This is someone in the who we got a procedure on, who we saw, who had a medical condition, who had atrial fibrillation. This is a CAT scan of the heart. This is in fact what's called the left atrium. So right above here on the front side, this is looking from the back. Right in the front is what's called the appendage. We spoke about it. That's where clots form. And these are the veins that drain blood from the lungs into the heart. Most people have 4, some have 3, some have 6. You may have, this is a CT scan we commonly perform if your kidney function allows before an ablation, to see how big is the heart chamber, how many veins you have, where they take off, and how they're oriented. So this is what normal, again, most physicians and most cardiologists get dizzy when they see these pictures. So if you get dizzy, just close your eyes. These are some of these can be very difficult, but I try to be more visual, less words. So this is normal electrical activity in the heart. Okay, this is someone we did about a month ago, and I saw him back up today. Actually, he's doing great. I don't know if he's in the audience, but he's doing pretty good. So this is a normal electrical action in the heart. Okay, this is inside the left atrium, this chamber that we saw over here in one of these veins. This is the vein firing. The reason you have atrial fibrillation is in the early stages, these veins start firing. So you see this electrical activity, it's one spike, and everything just speeds up on top. So suddenly normal becomes irregular and erratic. It comes fast, tick, 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 tick. And initially when this happens, this lasts for 5 seconds, 10 seconds, 20 seconds, 30 seconds. Over time, in the next few years, in the next 4 or 5 years as we spoke, this is going to become longer and longer until the whole atrium becomes chaotic and irregular all the time. That is an advanced stage of the condition, difficult to fix. Some people stay in this condition in the stage of episodes come and go for 10 years. I have seen people like this, but most commonly Once you start having episodes which last longer and longer, it becomes a bigger problem. So this is what a map of the heart looks like after we're done. So we use this catheter called an ablation catheter, which we put at these spots which we cauterize. What we do is we don't stop the firing in these veins. What we do is we prevent them from electrically communicating with the rest of the heart and causing atrial fibrillation in the heart. So the veins will still fire, but they don't cause chaos on the top. This is someone who's in a very early condition, very early situation in the game. He's above 65, but his heart is otherwise so healthy, and we picked him up so early, he doesn't need to be on long-term blood thinners or anything. This is what we call a squid. It's a catheter which has a lot of splines. This is just to record this electrical activity and chaos in the top chamber of the heart. Hopefully this illustration was a little helpful. So this is what the map looks like in the end. There is still firing going on in the top. It's not as active. It's not like what it was before. It's less. But you watch this heart, the heart rate on top. Once you're disconnected, everything else is nice and ready. So the veins will keep firing, but now they don't cause any problem. They don't talk to the heart anymore. They're electrically disconnected. No more problems. This is something I just will touch briefly about. This is what's called atrial flutter. This is a very well organized electrical activity in the top right chamber of the heart. It is much easier to permanently cure with a procedure. Often this and atrial fibrillation coexist. If that's the case, we will fix both of them at the same time. This is generally a curative procedure. About 50% of people who have atrial flutter alone in the next 5 years of their life will develop atrial fibrillation, about 50%. So that's the approximate statistic. Again, this is a map, colorful map. What it tells you is electricity goes around and round in the right upper chamber. See, this is a very focal problem. We fix this short circuit in this bottom part, and it's done and good. And we don't need to worry about this coming back. So this compared with this, where there is a lot more work that needs to be done. These maps are colorful, I like this. So lastly, who needs a pacemaker? Why do some people have a pacemaker? Well, just like the electrical activity in the heart spreads and causes the electrical malfunction spreads and causes atrial fibrillation, similarly your own pacemaker of the heart often slows down from the same process. And if your heart rate is too low, if it's too low, you need a pacemaker. A pacemaker does not stop your heart from going fast. It stops it from growing too slow. That enables us to give you medicines to prevent the heart rate from going fast. So it's a backup mechanism which allows us to treat your fast heart rate so you don't have the fast regular heart rate. This is what a pacemaker looks like here, by the way. Some of you may have it, some of you know people. It's an implanted device. It's the size of a small cell phone battery. It goes under most commonly in your left upper chest and generally has 1 or 2 wires which go to the bottom chamber of the heart, bottom and top chamber, gets screwed in, and everything goes inside. More websites to look at. There is something on Lakeland, otherwise myafibrisc.org, myafibrisc.com, myafibexperience.org, and so on and so forth. So certain people who have a little more advanced information about it, read about it online, there is something called CRYO ablation, cold ablation, freeze ablation. They ask me, do you do freeze ablation? Why don't you do freeze ablation? Why should I get freeze ablation? I don't perform freeze ablation for a couple of reasons. A, it requires much more X-ray exposure. In this day and age, we're getting scans, CT scans, X-rays, procedures, angiograms, stents. Who knows how much is the long-term effect of getting more and more radiation? When we perform this ablation right now, the amount of X-ray exposure you get is about the same as 2 or 3 chest X-rays. The amount of X-ray exposure that you get from a heart stent is approximately 50 to 100 times more than that. So we don't quite understand this. We don't quite understand the long-term implications, but neither did, I'm not trying to scare anybody, but neither did the people in Hiroshima and Nagasaki for many years, or Fukushima. So we try to minimize exposure. This has a lot more radiation exposure. That's one reason why I don't do it. And the other thing is I do it every day. You get it once. I don't want to be standing there getting hours of radiation exposure and not grow a third leg or fourth hand. The second thing is the procedure has an unavoidable, so far, risk of a complication called phrenic nerve palsy. That's where half of your diaphragm gets paralyzed. It happens in about 5% of people. It's unavoidable in multiple research studies, whether it's out of Mayo Clinic, Cleveland Clinic, Johns Hopkins. It's unavoidable. It happens. It gets better, but it takes about 6 months to a year to recover. It's extremely painful. Imagine you just have half your exercise capacity. You went in to feel better, now you feel worse for about 6 months or a year. So 2 reasons why we don't do it. It's about as effective for atrial fibrillation as the ablation, which is basically the heart procedure, but we just avoid those 2 risks of radiation and the nerve palsy, the diaphragm palsy. Some of you may have heard about it. This is just newer and coming through. WATCHMAN. WATCHMAN is a device to close, my friend, here, the left atrial appendage. It's a plug. It looks like an umbrella, as you can see it here. This is made of a metallic frame and has a mesh on top. The idea of this mesh is, since clots in atrial fibrillation form in the appendage, if we were able to plug and close that appendage off, why would we have to worry about being on a blood thinner, right? Everybody wants to live forever and not be on blood thinner, not be on medicines. So we fixed one part of the problem with atrial fibrillation ablation, but what about blood thinner? So this is a procedure where they plug this appendage. This has a mesh. It takes about 6 weeks to 3 months to close off, and once it gets sealed off completely, clots can't form. If they form inside, they get sealed inside, they don't come out. You don't have to bother about being on a blood thinner. Medicare recently, all of us are ruled by Medicare, you people and I, everybody's ruled by Medicare. Medicare came out with a rule, only people who have atrial fibrillation, who have a high risk of stroke, who can take warfarin for at least 3 months, Coumadin, not any other blood thinner, but Coumadin or warfarin for 3 months, but cannot take it for more than 3 months. And so if you can take it for 3 months, but you can't take it for 3 months, then you are able to have this procedure. It's still in a very preliminary stage. There are people, if anybody is interested in getting, and the other thing, sorry. Another thing is you need to have a very good reason to not take Coumadin longer. So you can't tell me I don't want to take Coumadin. That's not acceptable. You should either have had a brain bleed or had a stomach bleed when you were on a blood thinner, or you're on other blood thinners, or you're considered very high risk for bleeding or falls. Those are people who, or you had a stroke while you were on a blood thinner. Those are people who are eligible for this. If anybody's interested, we don't perform it here right now. There is hospitals in Chicago and in Grand Rapids. If anybody's interested, I'd be more than happy to refer you to get this done. But those are the criteria you have to meet to be able to get the procedure. Questions, comments?
And Dr. Beri, we have microphones, so if you could wait till a microphone gets to you. And we're videotaping this also tonight, and so if you could repeat the question for the recording, that would be great.
The ablations, how much have they improved the procedures in the last 10 years?
So the question is, how much have ablations improved in the last 10 years? If you look at research studies, the success rates have gone up by about 15%. The procedure duration is down about an hour and a half. I haven't had anybody have a stroke on anybody I've done a procedure on. So complication risks have gone down markedly. So complication risks are a lot better. Radiation exposure is less. Success rates are, for someone who has on and off atrial fibrillation and has no other significant risk factors, is close to about 70% with a single procedure. It used to be at 45 to 50%. And hospital stays and procedure times are shorter. So it has gotten better. It's not 100%, but it's much, much better than what it used to be 10 years ago. Maybe that answers the question. Any other questions? It's a lady back there. We'll come to you.
How long after the ablation can you resume normal exercise?
So the question is, how long after an ablation procedure can you resume normal exercise? From your heart standpoint, if we were able to perform it without putting an IV line in your groin, you could run a marathon the same day. Your heart does not have any stress. What matters is bleeding from your access site. We use veins for this, so the risk of bleeding is much less than would be for an angiogram or stent, because that's from an artery, which is much higher bleeding risk. Typically, what we like to do is avoid lifting anything heavier than 10 pounds, going up and down stairs a lot for at least 5 days after the procedure. So if you have a spouse, make them take out the trash, vacuum, do the dishes, make the bed, fold the laundry, everything. Okay. Hopefully that answers. Go ahead, ma'am. Yes.
If the fluttering of the heart is maybe the beginning of heart problems, I spoke to my doctor about it. If it only happened, let's say, 4 times in the last 6 months or 9 months, would you suggest that someone have an EKG who's never had one?
So an EKG, the question is, if you've had 4 episodes of fluttering in the heart, which lasted about how long? 3-4 minutes. So 3-4 minutes, that's above our cutoff of 30 seconds. If you have 3 or 4 episodes in the last 6 months, which lasted 3 or 4 minutes or longer, you could have, should you have any kind of testing, you should have at least an EKG performed. However, an EKG is a 10-second perspective. Someone like yourself, without trying to give you medical advice, would need to have an implantable monitor, because the frequency of episodes is rare enough that no other monitoring short of an implantable monitor will pick it up. Now, if you're very savvy, you can have a handheld monitor. I showed you something called an Alive Core. You Google it and look at it. It's FDA approved. It's about $75, and you need a smartphone for it. The problem is, by the time you find that app and you find the thing and you turn it on and you connect it to Bluetooth, often the episode is passed. So generally, if you have an episode where it lasts 3 or 4 minutes and they're very rare, you can wait for them to get worse and more frequent. But remember that the first sign may not be a longer episode, the first sign may be a stroke. So you want to find out what it is proactively rather than retrospectively. So very good question, and hopefully that answers the question. And go ahead, sir.
When you have this fish, as you said, that flip-flops in your heart, is that really an indication of AFib, or is that just an indication that's coming around that it may lead to AFib?
So the question is, palpitations or flip-flopping in your heart, sorry. Flip-flopping in your heart, is that an indication of atrial fibrillation or a marker for it? So there can be a lot of things which can go wrong with the heart's electrical system. It could be from the top, it could be from the bottom, it could be a different kind of electrical short circuit, or it could be atrial fibrillation. That being said, if your episodes of flip-flopping and the irregularity lasts for, as the lady said, more than a few minutes, chances are this is probably atrial fibrillation. Now sometimes skipped beats can mimic atrial fibrillation, where you feel boom, 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 but that's every few seconds or every 10-15 seconds. That's not atrial fibrillation. That's a separate condition, and that does not have the same bad potential side effects that can happen from atrial fibrillation. And someone over here. Yes, sir. Here's your microphone.
Yes, my question is that I had an operation before. We had the operation last year in January. What is my chance of maybe having another heart attack or stroke with this AFib operation?
Individual medical advice difficult to give, especially in a public format. But in general, as we went over, if you're above 65, if you have diabetes, and you can go over this in your head, if you've had a stroke in the past, if you've had any stents, bypass surgery, heart disease, if you've had congestive heart failure, any of those, or if you're a female, which you don't have to worry about, then your risk of stroke is elevated. How much it is, it has to be individualized based on these risk factors.
Okay, I asked this question sometime now. I have that flirting that I was having. I don't have it here anymore, but I be having it down here at my side here. What's causing that?
I do not know, but I would love to see you in the office and we can talk more about it.
All right,
Yes, sir. Go ahead, Pat.
You've gone over the list of things to watch out for.
Yes.
When I was diagnosed, I was told that I had an enlarged heart. It didn't mention any of the other variables. I've lost weight in the interim and increased moderate exercise like Tai Chi to several times a week and that sort of thing. But is that even a factor?
So
the enlarged heart.
The enlarged heart. Okay. So the question was, the gentleman in the back had a history of an enlarged heart. And is the enlarged heart in any way responsible or related to the atrial fibrillation? So, as I said earlier, as we get older, our heart arteries tend to get stiffer. Everything gets stiff. I noticed it from 10 years ago. I'm sure many of you have noticed it from 50 years ago. As everything gets stiffer and the arteries get stiffer, the pressures in your arteries gets higher. When the pressure in the arteries gets higher, the heart has to pump harder and harder to pump blood out. Imagine having a 1 pound dumbbell to lift every time your heart beats. It doesn't seem like a lot, but your heart beats on average about 90,000 times a day. If you multiply that number over the next 30, 40 years, when you've had high blood pressure, adds up to about 2 billion. So if you lift a 1 pound dumbbell, just a 1 pound dumbbell, 2 billion times, imagine what your arm would look like, right? So the same thing starts happening with your heart. This heart muscle starts getting enlarged because of the high blood pressure. That pressure backs up into the atrium, the left atrium, and that makes it bigger and irritates those veins, and that's when they start firing. So the high blood pressure and the enlarged heart are both a cause and a manifestation of the atrial fibrillation. You're absolutely right in assuming that.
What does the term nervous heart mean? Nervous heart.
What does the term nervous heart mean? I will point you to the slide here. It could merely mean that you're nervous. There's a lot of things that doctors used to tell people 40 years ago or 30 years ago, which today we laugh at. And 30 years from now, somebody's going to watch this video and say, what was this idiot talking about? so not to undermine your question, but a nervous heart can mean that there is an actual problem in the nervous or the electrical system of the heart. Not that it means you're dying, but it means there's a problem in the electrical system. Or a lot of people are very sensitive to their heart's electrical activity. Every time they have a skip beat, they feel a flutter, they notice it, and they're very sensitive to it. So it could mean that you're just more sensitive to your heart, or could it actually mean that there is a problem that you need to be worried about? Lady back there.
Having a hole in the heart, is that a risk factor?
Very, very good question. The question is having a hole in the heart a risk factor? This will need to be a little more medical, so again, if you don't follow it, that's okay. The answer is focused to the lady in the back. It depends on how big the hole is and how hemodynamically, what's the significance of having a hole. If you are 70 years old, and I'm not saying you're 70, but if you're 70 years old or 80 years old, or some people who are 85 would have a hole in the heart, it doesn't mean anything. You've had it for 85 years, it is unrelated to that. On the contrary, if you're 30 years old and you have a loud heart murmur, if you're 20 years old and you have atrial fibrillation is not just the main problem. The main problem is the hole in the heart, which leads to infection. Yes, ma'am.
I have a mitral valve prolapse, and recently I have had some AFib episode, and I wanted to know how can I see the difference when I have palpitations, if it's my mitral valve or if it's AFib, and would an ablation be something I could consider?
Very good questions. The question is mitral valve prolapse. If you have had mitral valve prolapse and you have palpitations related to this, and also atrial fibrillation, how do you tell them apart? We'll go a little bit into mitral valve prolapse. We're getting close to 7 o'clock. I am perfectly fine staying here, but if anybody wants to leave, feel free. So mitral valve prolapse is a condition where your heart valves, this is the aortic valve, but there's a mitral valve between the left atrium and the left ventricle, or the left upper and the bottom chamber. This is not designed to show valves. This is floppy. It's not of normal structure, and we call it degenerative. It means it doesn't have normal tissue structure. Over time, it starts leaking. And when it leaks, it increases the pressure in the left atrium. It irritates those veins. The veins start firing and cause atrial fibrillation. If the valve is leaking a lot, then the problem is the valve. Then the valve needs to be fixed. If the valve is not leaking a lot and the problem is only the irritation of the veins, then the veins need to be fixed. We got to figure out, is the valve, the main thing is, if you have a heart valve problem which is causing atrial fibrillation, you want to fix the valve. But if it's the atrial fibrillation alone which is the problem, then we've got to fix the atrial fibrillation. That's individualized based on how much the heart valve needs and how bad the prolapse or leak is.
I don't need a microphone.
We're bringing you the mic, sir. Hold on.
I'm running.
I just wanted to also take this moment while Bart's getting to the front of the room. There is an evaluation in everybody's bag. Please don't forget to fill that out, and we'd love to have that on your way out. Thank you.
Is there any connection between AFib and branch block?
Bundle branch block?
Yeah.
Interesting question. So, again, very technical. I'm glad people are asking extremely technical questions. Some of you may not follow it, but we'll move on. So what the gentleman asked, is there a connection between atrial fibrillation and bundle branch block? So the heart's electrical system, the way it works, electricity from the top to the bottom comes down through two bundles. I'll move over here because I want you to be able to see it, please. So it goes down these two bundles. There's a left bundle and a right bundle. Some people can have a lazy bundle. Some people can have a completely blocked bundle. Does that by itself preclude or cause you to have atrial fibrillation? No. Can they both be correlated and be a consequence of something else going on? Yes. If you have congestive heart failure, if you have bad congestive heart failure, you can have atrial fibrillation and a bundle branch block. But they can often be coexisting independently without any correlation.
The left one is worse than the right or something?
Is the left bundle branch block worse than the right? In about early 1960s, they took 1,000 army recruits and they did EKGs on them. Everybody got an EKG. And when they analyzed these EKGs, about 2% of these guys, mostly men, had a right bundle branch block. About 1% had a left bundle branch, which means the left bundle was not working or lazy, and the other one, right one, was lazy. They followed these people for the next 20, 25, 30 years. Neither of them had a significantly different outcome than their cohorts who did not have a bundle branch. However, if you do have a left bundle branch block and you have something else going on, then it has a worse prognosis. If you have congestive heart failure with that or heart disease with that, then that has a somewhat worse prognosis.
Dr. Beri, thank you.